Now, hopefully you all know the phrase elephants in the room, otherwise this all is a bit silly. Basically, elephants in the room refers to when you're listening to something or discussing something and you have all these big worries, but actually no one seems to be talking about them. So quite often, if you have someone senior, say from the government, talking about a policy, we all sit there looking very positive and nodding, but actually above our heads are huge, big thought bubbles about the things that we're worried about that particular policy. And as Sue said, I've been in post as director for the Royal College of Midwives in Scotland for the last year. And what I've been doing is going round Scotland and talking to midwives. And so they've really been telling me what the elephants are in the room. And I think when we talk about them, we can really help to deflate them. So basically, I've given myself a task of having 20 minutes to talk about 4 elephants, so 5 minutes for each elephant. And then I'm going to ask you how far we've been successful in addressing the elephant in the room and helping deflate it, okay? So you're going to let me know. We're going to focus on continuity of carer today because it's in the Best Start review, but I know some of you will be here from England. It's also central to the Better Births review as well, so it's really relevant for you. And when I've been talking to midwives in England as well as in Scotland, this is the subject that really makes them very, very anxious, as well as quite excited. But I'll talk first about elephant number 1. So that's on call. If I could have a bigger elephant, we would have a really big elephant for this one. So it's the one that comes up time and time again where people say, what are you saying? We're going to be on call 24 hours a day, 7 days a week. Obviously, it would be terrifically good for our livers. But is that what the Best Start review is saying to midwives? So let's have a look at the actual wording in the Best Start review, because I think it's important we go back to that and we recognise what it actually says. So what it says is that every woman will have a primary midwife, and that primary midwife will have a buddy, and those midwives will be supported by a small team to provide the intrapartum care. Unless an elective operative delivery is required, and then they'll be cared by the core midwives in the hospital setting. That primary midwife will normally have a caseload of around 35 women at any one time, and she'll be the first point of contact for women in pregnancy and see them through the journey and be the orchestra of all the other services that the conductor of the orchestra of services that women might need during the pregnancy. So when a woman begins her labour, the primary midwife will normally be the first point of contact, but they'll also be the team who will be on 24/7 to take those labour calls. The midwife will be with the woman for labour and birth when she's on, and whether at home or in a midwife or obstetric unit. And as I said before, it'll be the core hospital team that provides care for an operative birth. The 35 women is a rule of thumb, and it does say that if women have particular vulnerabilities or high need, that the midwives will have a reduced caseload in those circumstances. So what it actually means then is labour and birth is covered as a team. It's not about one midwife covering for one woman's complete journey and being on call for that one woman for labour and birth. 35 women at any one time actually means for any full-time midwife, 3 to 4 bookings a month, 3 to 4 births a month for that midwife. And if you have a team of 6 midwives covering labour and birth, that means between 18 and 24 births a month. So that's 4 to 6 a week for that team. So that's less than 1 a day with 6 full-time midwives. So how does that compare to what midwives are doing now? And I think that is one of the real problems for NHS midwives at the moment, is to picture it, because they know how it feels right now to provide care, and no one's sitting around drinking tea and eating cake. You know, everyone feels that they are working as hard as they can possibly work. And so then they think, well, and then you're going to add in labour care to my role as a community midwife. But actually, community midwives in Scotland at the moment average a caseload of more than 100 women a year. So that's 3 times the proposed caseload. Community midwives also, therefore, have to cover a much bigger geographical patch than they're going to have to cover in a new system with smaller caseloads. So where you currently have a team of 6 whole-time equivalent midwives covering that number of women, there'll actually need to be 18 whole-time equivalent midwives. So that is a big shift of midwives from mainly working in a hospital setting to working in a continuity model. So if you think, I used to work in the borders, and so I find it really helpful to think about BGH because it's got a nice round number of births. It's got 1,000 births a year. So for me, that's helpful to begin to think, well, what would that actually mean? Or Cresswell in Dumfries as well. 1,000 births a year, that's generally about 21 births a week for the whole health board. They're currently all cared for by 5, who are currently all cared for, and in the future, they'd be cared for by 5 continuity teams and then core staff. The way that they're currently looking after that number of women is by having the staff based in the labour wards 24/7 with 4 to 5 midwives on at any one time and a band 7 each shift. So it isn't that the workload's going to be different, it's going to be about where the midwives are based. So what does a week's work for a continuity midwife look like? A full-time midwife, unless she's on leave, will cover the antenatal and postnatal appointments for the women that they're the primary midwife for. So that's about 1 booking a week. It's about 10 antenatal appointments a week for that full-time midwife, and it's 5 postnatal appointments a week. And then, in addition to that, she will share the intrapartum cover with her team between the 6 of them, if there were 6 whole-time equivalent midwives in that team. And they can generally, between them, expect to look after 5 to 6 women a week to give birth. So if you think of a week having 14 12-hour shifts or cover periods, you're actually seeing that around 8 of those, the midwife won't be called out, who's on call for that, because she won't be looking after someone in labour. So Royal College of Midwives, we're a professional organisation, so we need to lobby for really high quality maternity services, and that's why we're supporting continuity of carer. But we're also a union for midwives, the leading union for midwives. And so we need to be absolutely clear that we have some golden rules about any new system that's there. We need to be clear about the law, about employment policies and the regulations to make sure that midwives get enough rest. They have clear time off, they're not working excessive hours. And so we'd really encourage all midwives to make sure that they're seeking support and guidance from their union local reps, and that staff side are included in the implementation process locally. Each midwife needs to have 2 full 24-hour days off each week. They shouldn't be having an on-call that goes for longer than 12 hours at any one time. We shouldn't be looking at a system where midwives might be out caring for a woman for 24 hours. And the break relief still all apply in any new model. So this is going to be way too busy for you to have a look at what we've been trying to do. We've had a focus group of community midwives from Scotland come and spend time with us in the office at RCM Scotland to look at what a rota might look like. And what we've come up with is we're developing a kind of suite of example rotas for people to have a look at so that they can start to picture, would that work for me? Would that work for my colleagues? The reds show your time off. And so what we've got is we've divided it up into those 14 12-hour blocks, if you like, in there. And what that shows is how a team of 7 with 1 on annual leave there, so 6 whole-time equivalent midwives working, can cover the intrapartum and labour care, and then the midwives will slot the antenatal and postnatal visits that for their women around those sessions. So what I want you to do is put up your hand if you feel we've gone some way to deflating that elephant that fear that people have, that you're going to be on call for 24 hours a day, 7 days a week. So if you could put up your hand if you feel that we can begin to deflate this elephant a wee bit. Go on. So Tracy, my lovely assistant, who's a caseworker with the RCM Scotland team, can you keep your hand in the air? And then Tracy's going to start deflating it to the level that you think we've deflated it. Okay? And then if you think, right, that's enough, you know, there's still a lot of worries that I have there, put your hand down. Okay, so some hands are going down, but some are staying up. Some are staying up. Okay, probably more than half the people now have put their hands down, so we'll leave it there. So we've deflated it a bit. Obviously in 5 minutes, there's a limit to what we can do. So we need to keep doing lots of sessions locally and around the place to make sure that people understand the impact that this new model would have on their lives. That is the biggest elephant, so it is the one that I bang on about most. So we'll be able to get through these next ones a wee bit quicker. Good. Elephant number 2. What if I want to carry on working in the hospital? What if that's what I love? If that's the thing that really floats my boat and that I've got all my skills in? I've been a labour ward midwife for 15 years. Why would I want to go and work out in the community? So as we all know, especially as we get older, a strong core is absolutely key to many things. And that is true of a continuity system as well. We will absolutely need a strong core of staff, midwives, support workers, obstetricians, all of those people who are there in the maternity units providing cover 24/7. They'll need to cover unexpected admissions, elective births, query inductions, especially the initial bits, emergencies, feeding issues on the postnatal ward. I started my career as a core midwife in a continuity system, so I can see how that works, where you provide part of the care and then you call in the continuity midwife to provide the rest of the care to that woman. We're still going to need specialist midwife roles. We're still going to need managers. We're still going to need leaders and consultant midwives. We're still going to need researchers and lecturers as well. There's still lots and lots of different roles that we're going to need in midwifery. And we're going to need enhanced need teams that are based in hospitals. And we've got examples of that in different parts of the UK. There's a team called the Tower Team in London who provide high-risk care for women. They provide continuity of carer along with their obstetric colleagues in a hospital. So it doesn't mean that all the midwives are going to be sent right out into the community. And it's certainly not going to be over a cliff edge. It's certainly not going to be right in February 2018, that's it, out you all go to the community, jumping off the cliff together. The way I see it is the only way it's going to really work is that if we do it gradually. And we've got really good at that lately in Scotland with lots of quality improvement initiatives where we do small tests of change. If it doesn't work, we consider again, we see how that's going, and then we take another step. And we widen it out from one woman that we're looking after, don't we, to many women that we're looking after. So we've been doing that for years now with the Scottish Patient Safety Programme and McQuick. And I think it's going to be really helpful for us to use those models of quality improvement as we implement these kind of changes. So it will need to be a gradual shift. Okay, so elephant number 2, Jackie, National Officer with the RCM in Scotland, is going to come and deflate the elephant on your instruction. So if you feel that we've managed to deflate that elephant a bit, that you're not all going to be sent out from the hospital to the community straight away, please put up your hand. That's good, keep going. That's quite a lot. Okay, so just put down your hands if you think Jackie's deflated that elephant enough, but keep them up if she can keep deflating. Yeah, I can keep deflating. It's like you've got the pipes, isn't it? That's good. Okay, that's probably enough. Thanks very much. Good. Elephant number 3. We did it before and it didn't work. So lots of us in the room are old enough that we remember some of the models that we had, some of the teams like the Meadows team here in Edinburgh in the 90s. And we often will say, or I'll hear people saying, well, we did it before and it didn't work. We had Changing Childbirth in 1992, and that was all about choice, continuity and control. We had little pilot schemes that went out. There was the midwife-led unit in Glasgow and a randomised controlled trial there. Forth Valley had a team system that went for a long time, but then evolved into much larger teams that really didn't provide continuity. So they tended to come to an end in the early 2000s. So the perceptions about those models were that the midwives that worked in those continuity teams was kind of a bit odd. You know, they were unusually keen, maverick midwives who didn't mind being on call constantly. And so sometimes those midwives, I think we were our own worst enemies because we did kind of push ourselves too far and put ourselves on call too much. So it was seen like, well, I'd never want to be one of them. Some of the continuity midwives then became burnt out because they did go on call so much. There were also real difficulties in that relationship with the corps. Sometimes, I had experience of that, of the labour ward midwives being quite resentful when the continuity midwives came in. They felt that they spent most of their time out there in the community drinking tea. So when they did come in, they thought, well, I will make her work and I will not relieve her for a break. So there was quite a them and us situation that arose, and that led to real difficulties for those continuity midwives. It was also seen as expendable because often it was for the women who needed that care least. It was for quite well-educated women. For example, in Edinburgh, it was for women in the Bruntsfield area. So those were women who weren't particularly vulnerable and deprived. And so then it can be seen as a bit of a gold standard that you can get rid of. Because why should you have that gold standard of care when all the other women who actually have greater need are getting less good care? But what I would say is I would challenge that they didn't work. They did work for women. All the evaluations, all the randomised controlled trials did show improved outcomes for women and babies. And the reasons those schemes came to an end isn't because they didn't change outcomes. They were because there wasn't the support at the top. There was a perception that it wasn't making enough of a difference because people didn't evaluate those models of care. They just provided them. That it was only low-risk women that were benefiting, and that there was a burnout of midwives, but partly because there was this real them and us thing. And then the teams got so big that actually they became a bit meaningless because continuity really went out of the window in terms of continuity of carer. So I think we can learn from the past, and I think there are real differences this time. One of the key differences for me is that we've got absolute government support at the top. We've then got all of the heads of midwifery who are completely signed up for it. We've got the obstetricians at the top and the RCOG supporting this shift because they can see the evidence now is so incredibly strong that it's very hard to argue against. So I think we need to also learn from the present. We're not happy with the kind of care that we're able to provide at the moment. But we also know there are some continuity teams, particularly down south in England, that have been doing this for a number of years, and they've been doing it really successfully, and the midwives haven't been getting burnt out. So we can get loads from them, learning from them, and there are also now some really good examples developing in Scotland. And if you go to that workshop later with Iona Duckett, there's a fantastic model that's been developing in Argyll over the last couple of years as well. So we can learn and we can step back from a conveyor belt of care that hasn't been working for us as midwives for years, as well as for women. Good, so do you think we can deflate the elephant about it didn't work before and so it won't work again? Put up your hand if you think we've managed to deflate that a bit. Good, Tracy's going to deflate that elephant. That's me with my 18 minutes up. Good, so put your hand down, if not just because it's aching, just good. Yeah, we'll probably stop there. They're looking quite nice and deflated, actually. It's really good. Good. Elephant number 4. Where's the money? What's the cost of this? From the randomised controlled trials, what we know when they've done the economic analysis is that actually when you implement this kind of model of care of continuity, you can actually have it cost neutral or actually reduce costs. And that's mainly to do with the fewer number of interventions that you get with a continuity model of care and fewer number of premature babies that are going into special care baby units as well. Midwives also really worry that we don't have enough midwives in the system. We don't in England. That is absolutely true. They are at least 3,500 midwives short in England, and so it's going to be particularly challenging for them to implement. But actually, when you look at the figures for Scotland, we actually do have enough midwives in our system to actually provide this model of care. And I won't bore you with those figures, but you can go back to these later if you want to. But we do have a lot of midwives who are retiring now. So we do need to make sure that we're really keeping pace with those retirees and making sure that we're keeping the student numbers up. There are going to be costs of making it happen. The early adopters have got some Scottish Government funding to implement. There's a commitment in the review to fund education, but that education needs not just to be some e-learning resources. It needs to be actually allowing midwives who have only worked in one kind of system, community or hospital, to really shadow their colleagues in the other place and really learn the ropes to feel confident before they're being expected to provide that kind of model of care. And we're really arguing for that at the Royal College of Midwives at every level, at every meeting that we're at, to make sure we have that level of commitment to really successful implementation. I also think this is our time in the sun in maternity services. The CNO, the CMO, all of these people are talking about the Best Start review and about continuity of carer. And the Cabinet Secretary, Shona Robson's on the TV talking about the Best Start review. So this is our moment to say maternity is really key to setting up babies for a really good life. And so that's how we can argue for more resources, I think, a bigger slice of the pie locally with health boards. So we need to take that opportunity right now. But we also need to know that there's going to be some real tangible costs to this, to creating the infrastructure to make it possible for midwives to provide this kind of care. So that's things like cars, that's things like the IT systems, having an iPad, all of those things we need to make sure we've got sorted. Great. So can Jackie begin to deflate the elephant about not enough money, not enough midwives in the system? So if you think we can deflate the elephant a wee bit, can you put your hand up? That's good. So there's maybe fewer for this one. It's a bit like elephant one, maybe. Put your hand down if we... Good. So that's good. Okay, maybe stop right there. Thank you very much. Good. That's our time up. Just to say the Royal College of Midwives is going to be by your side supporting you along the way. We're running regional events. We had a very successful one for the West last week. We're going to have one for the East in Edinburgh in January, and then up in Highland later in January as well. But also do make sure that you're going to your local branch meetings, talking to your local reps, and that they will then be feeding up to us, RCM Scotland team. Do follow us on RCM Scotland on Twitter and on Facebook as well to stay in touch with everything we're doing. Thank you very much.